So, over the weekend, it became quickly apparent that the CDC had completely botched its rollout of the vaccines, at least in terms of its initial standards. So, the standards are still being set. They had not yet been finalized, but it became very clear, and we talked about this last week at the end of the week on the podcast, that the CDC had been taking into account race as opposed to just pre-existing condition and age as factors in who would get the vaccine, which is totally crazy. I mean, that's utterly insane. The reason that is insane is because that is highly, highly unlikely to save lives in the same way that tranching out by actual vulnerability to the virus would be saving lives. And just on a pure statistical level, if you want to save the most lives, then you help the people who are the most vulnerable. You don't tranche out support to people who are less vulnerable. I mean, this is perfectly obvious to anybody who has a shred of both reason and morality. That's all it takes to come to the conclusion that the way that you give out the vaccines is you find the people most likely to die and you give them the vaccine first. End of story.
That would be the case if we were talking about a cure. We are not. We're talking about a vaccine. According to the CDC, vaccines work by imitating an infection, but almost never causes illness. So, if you have a mechanism to prevent illness in the first place, who should get it first? Old people or frontline healthcare workers?
The CDC has issued guidance on its social vulnerability index that uses 15 U.S. Census variables to help local officials identify communities that may need support. It is being used in states like Michigan, where minority status and language spoken could be taken into consideration when deciding how high a priority you are for receiving a vaccine. Maine has developed a racial ethnic minority COVID-19 vaccination plan in an attempt to give preference to groups that, quote, have experienced rates of disease that far exceed their representation in the population as a whole. In the U.S., Black and Hispanic people are almost 3 times more likely to die from COVID-19 than whites. Well, the reason that is because Black and Hispanic people are apparently significantly more likely to actually get the disease. It turns out that it is not that they are particularly vulnerable to the disease. According to the New York Times, there's a piece over the last couple of weeks. Dr. Gabenja Ogidegbe, forgive the pronunciation, began to research coronavirus infections among Black and Hispanic patients. He thought he knew what he would find. He thought infected Black and Hispanic patients would be more likely to be hospitalized compared with white patients and more likely to die. That's not how it turned out. So in other words, Black and Hispanic people do not have an innate vulnerability. It has nothing to do with race. What's actually happening is that Black and Hispanic people, because they're disproportionately low income, are more likely to actually get the disease. After accounting for various disparities, Dr. Ogidegbe found that infected Black and Hispanic patients were no more likely than white patients to be hospitalized. If hospitalized, Black patients had a slightly lower risk of dying. That study was published in the journal JAMA Network Open. 3 other recent large studies have come to similarly surprising conclusions. The new findings do not contradict an enormous body of research showing Black and Hispanic Americans are more likely to be affected by the pandemic. The coronavirus is more prevalent in minority communities. Infections, illnesses, and deaths have occurred in these groups in disproportionate numbers, but the studies do suggest there is no innate vulnerability to the virus among Black and Hispanic Americans. He says it's about exposure. It's about where people live. It has nothing to do with the genes. Okay, well, then why exactly would we be looking at non-health variables in order to determine how to tranche this stuff out? I mean, this is insane.
There are many variables in the math, so a model may come out differently based on the inputs, and trade-offs are unpleasant even in less dire circumstances. But here are some advantages to prioritizing frontline healthcare workers over old people, regardless of race. If a frontline healthcare worker gets infected, they are out of commission for a minimum of 10 days, during which they have to quarantine, and possibly longer if their recovery is more complicated. Trained medical personnel is a constraining factor when ramping up hospital capacity. Having ventilators is of little use if there are not enough people around who are trained in their use and other related tasks. Making sure that healthcare workers can work means that more patients, including old people, can be treated and have a better chance at survival. Younger healthcare workers may also be asymptomatic, and if they are not regularly tested, or if tests show false negatives, they may spread the disease to more vulnerable people. If a frontline healthcare worker does die or suffer long-term effects from the virus, they should be entitled to compensation for injuries on duty. By reducing the number of frontline healthcare workers who are infected by the virus, this monetary cost can be reduced. While any monetary discussion may sound callous to some, savings on these costs could be used to purchase more vaccines or help fund unemployment benefits that can allow non-frontline workers to stay at home and avoid crowds, risking getting and spreading the infection. Furthermore, those medical workers who can afford to do so may choose to leave the profession, while those who cannot may be stuck. Exposure to highly infectious diseases is not something most medical workers are expected to face on a daily basis under normal circumstances. There should be some moral concern about drafting people to put their own lives at risk, especially as at least some of the patients they have to see will have gotten the virus from engaging in high-risk behavior. Perhaps more importantly, if we work from the basis that healthcare workers tend to be disproportionately Black and or that Black people in the United States tend to be disproportionately poor, healthcare workers are more likely to live in households where it may be difficult to isolate and may also make disproportionately higher use of public transport, not only putting themselves at risk, but also those they live with and come into contact with. People who have fewer socioeconomic resources are more likely to live in multi-generational homes, so that may very well include old people as well. If you want to save the most lives with a vaccine, you do not give it to the people who are the most likely to die. You give it to the people who are the greatest vectors of transmission. That is to say, if you want to save lives with a vaccine, you give it to the people who are the most likely to spread the disease. That simply isn't the people in old age homes with limited mobility. By giving a vaccine to people who are the most at risk and who cannot realistically take other precautions, such as working from home, you're protecting the lives of the so-called rich old white people too.
This is good stuff. One problem. It turns out your public health experts are screwing everything up. So it turns out now that they were tranching out the vaccine, that they'd been telling people that it was time to tranche out the vaccine by using racial equity issues as opposed to looking at how many people to save. This has all sorts of statistical implications that actually end with more people of color dead, right? If we had actually followed these standards, more people of color would have died. I'll explain in 1 second. But first, here's what you need to know. What you need to know is that if you vaccinate by age, you will be preventing the most death, and it is very clear that this is the case. Okay, age is actually even a better way of describing how people should be vaccinated than single pre-existing conditions. Now, the reason for that is because if you are 85, the chances are that you have several pre-existing conditions. So if you just look at people who have diabetes versus people who are over the age of 85, people over the age of 85, just as a group, are more likely to die than people who just have diabetes, because if you have diabetes, you could be 30, you could be 35, maybe you have your diabetes well handled. Okay, if you're 85, the chances are that you probably have diabetes, you probably have a kidney problem, you probably have some lung issues, right? You're 85. I mean, you've lived a long time, and that means that you have multiple underlying issues. It doesn't mean that age itself is the complicating factor. It means that age itself correlates with multiple underlying factors. This is something that Dr. Marty McCary from Johns Hopkins University had talked about extensively, is that for people in the United States above the age of 65, as of about a month ago, only 2,500 people above the age of 65 with no pre-existing conditions had died. So pre-existing conditions still matter, but it's multiple pre-existing conditions that give the game away in terms of like very, very high rates of death, and that correlates very highly with advanced age, not only in the United States, but all over the world. So statistically speaking, here's an example. This is from Israel, okay? So this has nothing to do with the United States or its racial breakdown. David Wallace Wells, who's a liberal, right? He's the deputy editor and climate columnist for New York Magazine. He put out this chart from Aryeh Kovler on Twitter over the weekend. These estimates are from Israel, he says, but striking. Vaccinate the 0.5% of people over 90. The total fatality risk drops by 19%, right? By 1/5. Vaccinate the 2.5% of the population over 80. It falls by half. Vaccinate the 7.5% of the population over 70. It drops by 3/4. Age skew remains underappreciated. In other words, pretty obviously, if you want to prevent mass death, then what you do, and you can see it right there in the stats. If you want to prevent mass death, then what you do is you do it by age. Fortunately, we have public health experts who are both not concerned with public health and obviously not experts, who are absolute idiots, right? They are suggesting that instead, for the purposes of racial equity, we should tranche out the vaccine with an eye toward race, which is nuts.
This video does not make the argument that race should serve as an approximation for socioeconomic factors. All living ex-presidents of the United States have agreed to take a C-19 vaccine when it becomes available to them, and there may be some value in boosting public confidence in the safety and efficacy of a vaccine, so Obama is not the best example. However, absent some sort of genetic propensity that makes Black people inherently more vulnerable to the virus, prioritizing an apparent billionaire like Jay-Z, who has the economic resources to self-isolate for many months, over a nameless, at-risk white person who needs to work outside the home to feed their children is indeed inherently unfair. That having been said, it is important to keep in mind that metrics for those who are more at risk need to be relatively easy to measure and to verify. That may not always be the case with income, housing situation, or means of transport someone relies on. Perfect fairness, if such a thing exists, does not help if it delays the distribution for too long.